So we're going to be talking about some sling systems today. Has anyone ever heard of the sling systems? Okay, the sling systems are interconnected muscles that go throughout our body in diagonal, longitudinal, or up and down, or and they sync together. So, for example, if I am performing a row and a hip extension on this side of my body, I'm connecting my right lat to my left glute. And it sounds a little kind of strange and a little complicated at first, but we're going to watch some NCSF video materials, and then I have some good videos on YouTube I think explain it a little bit better. But basically, you're going to see that the body is interconnected more than you may have thought. So certain muscles, like the external oblique, run into the internal oblique, okay? And so that forms what we call sling systems. The names are anatomically devised, so posterior sling system would be the backside, posterior oblique, meaning the diagonal pathways. But we're going to go ahead and get into that now. We're going to talk a little bit about high blood pressure, diabetes, and obesity today. So I'm going to kind of test you to see if you've been looking at the materials on your own. I did ask you to go over diabetes, those chapters on your own in that first module. So we're going to see if anyone was paying attention there. So let's go ahead and start with muscular units and postural distortions. So looking at kinetic chain and those sling systems.
In this lesson, we will cover key concepts related to the inner and outer units, as well as postural distortions. Let's begin by taking a closer look at the inner and outer units. As addressed in the previous lesson, body segments require stability to effectively transfer force across the kinetic chain. For trunk stability is especially detrimental, as energy transfer will be reduced during nearly all actions that involve the arms and legs. Fortunately, trunk stability is effectively managed by the inner and outer units. The inner unit is a collective group of local spinal and pelvic stabilizers. It includes the transverse abdominis, diaphragm, posterior internal.
And they will definitely want you to know what the inner unit is if you do end up getting certified. And the outer unit is going to be the sling systems.
Oblique, pelvic floor, and multifidus. The outer units are global systems that stabilize the spine and pelvis during movement and holding the extremities. It works with the inner unit to transfer force to the hands and feet across the trunk. They are also called sling systems. Let's further examine the inner unit. First off, we have the transverse abdominis, which helps to manage intra-abdominal pressure and flexion-extension movements of the spine. Delayed firing of the transverse abdominis is associated with poor stability and lower back pain.
What type of fiber is the transverse abdominis? Do you remember? Is it type 1, type 2A, or type 2X? Without looking. Remember, that transverse abdominis is stabilizer, so what muscles fire first? Are they the smaller muscles or the bigger muscles? Remember, we were talking about the force production. Muscles synchronize. They go from smaller muscles, medium muscle fibers, to large muscle fibers. What were those small muscle fibers types called? Type 1, right? So transverse abdominis would be one of those type 1 muscles.
The opposing side of the spine is the multifidus, which connects spinal segments and prevents various undesirable movements.
Multifidus is a very hot topic in the whole functional anatomy scene right now because it's almost like people forgot that there was a multifidus and people forget that there is a pelvic floor, and then we're realizing that all this stuff together makes up this inner unit. So more trainers are paying attention to this intra-abdominal pressure, and what we do, and when we get into our exercises, we're trying to create this intra-abdominal pressure especially if we're doing something like a deadlift, right? We don't want to be out of sync or out of kinetic chain, and so this intra-abdominal pressure sets us up for all of our exercises. So we're trying to find the intra-abdominal pressure. We're trying to create this inner or compact or stabilize this inner unit before our outer unit.
The multifidus works with the transverse abdominis to prevent changes in pelvic positioning and provide a natural protective weight belt effect. The superior aspect of the inner unit is comprised of the diaphragm. It functions as a local stabilizer for top-down support and also serves as a primary respiratory muscle.
Does the diaphragm lower or does it go up on your inhale? The diaphragm go down or does it go up on your inhale? It does. Yep, it goes down. It contracts and goes down, flattens, relaxes, and forms a dome on the way up. And also acts as a stabilizer on top of having to breathe 20,000 times a day.
Within the inner unit to keep the pelvis neutral and protect the spine from potentially damaging curvatures.
Pelvic floor, something really important for mothers especially. So my wife, she has to practice pelvic floor exercises because that area gets really loose and lax after pregnancy. And so you actually have to prepare that muscle tissue before pregnancy and then also have to work on it after pregnancy because of the effects of pregnancy. So I wouldn't prescribe or know how to prescribe those types of exercises. That's not for a personal trainer. That's for, who do you think? What type of a person might teach those types of exercises? Chiropractor? Physical therapist? What do you think? Physical therapist. So she sees, or she went to a physical therapist after pregnancy, but wishes she went before that pregnancy to get those exercises prepared.
It anchors and braces the pelvic vertical to handle loading of the trunk, such as during a back squat.
Stiff spine for those strong lifts.
The sling systems can be best understood as cooperative units of muscle and fascia that manage closed chain actions by producing slings of force that transfer loads across the body. The outer unit includes the posterior oblique, anterior oblique, deep longitudinal, and lateral sling systems.
Okay, posterior, is that my front or back? Back. Okay, oblique, what does oblique mean? It means diagonal. So it's a diagonal posterior view. Anterior, oblique, okay, that's again diagonal, front. Deep longitudinal, what does longitudinal mean? Yep, up and down. And then lateral. What muscles do you think would be part of the lateral subsystem? If I'm moving side to side or if I'm stepping upstairs, what muscles do you think need to turn on when I'm stepping upstairs or if I'm moving laterally? Yeah, what muscles specifically in the hip? So hip flexor, not as much. Any of the glutes, what glutes? Glute max. Okay, so glute med and glute med and minimus are involved. What else is this other muscle? My pocket muscle. Starts with a T. FL. Tensor fasciae lata. Okay. So, good, good. What might be a deep longitudinal muscle? Muscle runs down my spine. So the erectors, the spinal muscles on posterior side of the back.
The posterior oblique system includes the latissimus dorsi, gluteus maximus, and thoracic.
And you'll want to definitely know the muscles involved in each system. So just take that in consideration.
The lumbar fascia. It works with central stabilizers to form a force transfer bridge between the lumbar spine and pelvic girdle. The anterior oblique system works with the posterior system via the combined function of the obliques, adductors, and abdominal fascia. It creates cross-stabilization for the posterior sling and is integral to sagittal plane locomotion. The deep longitudinal system includes the erector spinae, multifidus, and sacrotuberous ligament, which connects to the lower extremities via the hamstrings. It links multiple joint segments to enable efficient sprinting mechanics. And finally, the lateral system includes the hip abductors, quadratus lumborum, and thigh adductors to provide frontal plane stability and aid climbing motions.
Where's that quadratus lumborum? Low back. Yep, that's your quadratus lumborum. So talk about when we're on one leg, your opposite QL turns on, that adductor turns on, and then your glute hip abductors turn on here. So those are the glute medius and minimus. Okay. So that would be the lateral sling stability that you need in order to go from one foot to the other, or to climb, or to step.
Such as going up a ladder or stairs. Here are a few examples of exercises that would activate each sling system.
Okay, so you have him pulling with his left hand. His right leg is forward, so it looks like going up, posterior oblique. I'm extending this right side, and I'm pulling this left lat, which crosses over and forms that posterior oblique. Okay, so posterior and then diagonal. So that's why it's this left lat and this right glute. Extending this right glute, firing with this left lat at the same time. So that's how you would operate that posterior oblique system.
The posterior oblique sling, we have a reverse lunge with row. For the anterior oblique sling, we have a forward lunge with contralateral forward cable press.
So contralateral, that looks like they're alternating. So if he is pushing with his left, he's lunging with his right leg. So it wouldn't be, you wouldn't see this. Just like you wouldn't throw with your left, step with your left and throw with your left. You think contralaterally, okay? Because we work in, our body is what we're showing you is that the body works in diagonal patterns, and the systems actually sling together, create a cross bridge for movement.
We have a forward lunge with contralateral forward cable press. For the lateral sling, we have ballistic side stepovers, and the deep longitudinal sling, ballistic extensions.
Okay, so stepping up onto the box, lateral sling system, step overs, and then you have your ballistic extension. So starting in that, looks like a Smith machine. See, we got his right leg forward, left leg back, and then, so it looks like we're using this right leg and extensors on my back to get straight here. Okay, deep longitudinal. It's going to probably run down into those biceps femoris as well.
Let's transition to making sure we understand postural distortions. Postural distortions impact joint function, increase the risk for injury, cause poor inner-outer unit coordination, and create major training limitations.
Okay, if you see someone that lacks coordination, you might want to work on these sling systems, right? Doing a bicep curl isn't going to work in a sling system. That's why when we look at functional training, bodybuilding, and Olympic powerlifting, we see that they're different, totally different things. And so when we're connecting these inner and outer units, we're looking at more of a functional training style.
Genetics can increase one's risk for distortions, but problems usually develop over time due to inactivity or chronically repeated motions.
Okay, who has a job that has a chronic motion? What would be a job that would be something that'd be very repetitive, might create imbalances in your posture? What do you think? Agriculture, farming, right? So we didn't see degeneration of the hips and spine until humans started to farm, and that's when we started to create postural changes and adaptations that were in a negative way. And then obviously with the, office job work life that we live now, people are sitting all the time.
Common causes of distortions and muscular imbalance include practicing poor posture at work or home, sedentary behaviors, repetitive training actions, poorly devised exercise programs, incorrect instruction or technique, and injury-related movement compensations.
Okay, very simple, but many people kind of look past this, right? Practicing poor posture at work or home, what is posture? What is the best posture to sit in? There is no good posture really to sit in or be in. Probably the next best posture is the best thing because movement is better than just sitting, right? Sedentary behavior is just not doing anything, just sitting a lot, repetitive training actions. So maybe you perform the same types of training styles all the time. Maybe it's a dominantly push, maybe you're pushing more than you're pulling. So you're pushing yourself into those postures. Poorly devised exercise programs, like again, training an adult, or someone that's in their 60s how to bodybuild, or getting them on the machines and not actually working stabilizers. So when you use machines and you're sitting down and you're pushing or pulling, you're taking everything out of it. So that's why I always recommend at least a half kneel, or where you actually have to use your whole body when you're pulling something, like a pull-up. It's probably the best exercise. Incorrect instruction or technique, not understanding functional anatomy, not understanding that, if their pelvis is out of alignment, or their hips are out of alignment, their spine is going to be out of alignment. Understanding how to recognize that. If you got your client and they look like this, and you want them to have a lunge position, but their leg looks like that because they're not cued to put that heel over the toe, they could injure themselves. Okay. And if you do that repetitively, you're going to have muscular imbalances and then injury over time. And then injury, obviously is going to create compensations over time as well.
Now, postural distortions can be identified statically or during movement. A plumb line is used to observe static variations in a person's body caused by postural distortions.
Okay, plumb line, just standing still. Take a picture. Look at their shoulders. Look at their hips. Look at their knees. Look at their toes. Look at their feet. Are their feet out? Are their feet in? Are their knees in? Are their knees out? Their hips, one hip higher than the other, one shoulder higher than the other. Is the head forward? So that's a plumb line, looking straight up and down.
A plumb line should go through the following locations from top to bottom if the client has no major distortions: the ear, the acromioclavicular joint, the central vertebral bodies, the greater trochanter of the hips, slightly anterior to the midline of the knees, and the anterior portion of the lateral malleolus through the ankle. Each client should be evaluated for issues in both static and dynamic postures. Fixing these issues starts by recognizing problem areas. Postural muscles and global movers often become too tight and overactive, or too weak and underactive. And overactivity of postural muscles tends to make them too tight, while overactivity of movers tends to weaken them over time. A few common postural muscles at risk for distortion include the upper trapezius, the later scapulae, spinal extensors, and hip flexors.
Where's the upper trapezius? Okay, right below the occipital lobe, or the base of the skull, in the posterior. So posterior inferior of the head, if you want to look at anatomical position. What about the levator scapulae? It's next to the sternocleidomastoid, if you know where that is. Okay, so it goes from here to here. It's on the lateral side of your neck. Spinal extensors, that's your erector spinae group. Okay, and hip flexors. Phasic.
Basic muscles or movers at risk for distortion include the lower mid-trapezius, abdominals, gluteals, and vastus medialis. Let's now take a look at specific distortions and how they impact function and training abilities. Postural distortions are usually categorized into upper body, lumbopelvic hip, and lower extremity issues.
So what is the lumbo-pelvic hip area? Where do you think that is? Lumbo meaning, what is lumbo? Lumbar, or where's the lumbar? Lower back. Okay, pelvic, hip. Okay, so this whole complex in here, and then lower extremities would be the legs.
By examining upper body distortions. In the upper body, anatomical segments commonly migrate forward as seen here. Common issues with this migration include shoulder complex dysfunction, shoulder impingement, rotator cuff problems, scapular winging, and significant immobility.
Okay, if your client likes to walk, but they like to look down at their phones while they're walking, that's going to alter your posture. Okay, so maybe trying to think, make sure that you're swinging your arms and you're looking straight ahead at the horizon would be a good cue when you are walking. Just natural head movements is obviously fine. We don't want to be like this, but you do want to swing your arms in opposite. Sometimes you'll see people swing one arm more than the other. So if you watch people walk, you'll see that some people will use one arm more than the other. I'm not picking on Joe Biden, but when he walks, his arms are like this. Okay? That you need to have a gait swing to have a proper walk. Okay? So when you walk, you want to make sure that you're not going to the sides and that your hips are stable. So you can look at gait as a way to increase posture just by keeping good posture when you're walking and making sure that you're swinging both arms.
Distortion can progress from a forward chin, rounded shoulders, to upper cross syndrome, to severe kyphosis, to a major deformity known as Gallagher's hump.
Who knows an older individual that has this? Any grandparents out there that they kind of walk like this, right? They get stuck. They're not going to get to this position. It's too late. Your collagen fibers, your bone structure, your muscles have all led to this position. So it's going to be a while till you get back to here. So that's why we want to try to prevent stuff like this. Now, would you want to push into that area to try to go back? Probably not. Okay, it's not something that we're going to probably be able to change.
A Gallagher's hump is usually seen among the elderly and is more than just a distortion, as it's caused by skeletal changes that cannot be reversed. Let's take a closer look at the upper cross syndrome, as this is one of the most common issues among bodybuilders and sedentary individuals alike.
Okay, upper cross.
Those with desk jobs. With upper cross, there is reciprocal weakness and tightness surrounding the shoulder complex, as shown here. The lats, pectoralis, internal rotators, levator scapulae, and upper trapezius become tight, strong, and overactive.
Okay, so internal rotators of the shoulder. Okay.
While the neck flexors, external rotators, rhomboids, and mid-lobe traps become lax, weak, and underactive.
Okay, rhomboids. I can retract. When I retract my scapula, I'm contracting my rhomboids. What they're saying is if we're in this position like this, we're protracted, and so those muscles get long and weak, is what they're saying about those rhomboids. Those low trapezius, since we're doing upward rotation, has to move upward. Okay, or that's going to also become weak, and then tight pecs because we're always kind of contracted, right? So tight pecs, tight upper traps because our traps are up. Levator scapulae, which supports our position of our clavicle and head. That's going to get tighter because notice that when I go like this muscle here is going to shorten. It's going to get a little tighter.
The posterior capsule of the shoulder also tightens, making the situation cross syndrome is most often caused by repetitive shoulder movements, poor seated posture, and imbalanced upper body training.
Okay, so you're sitting at your desk all day. You go to the gym, you're doing your bench press, you're doing your incline press, you're doing your curls, you're doing your hip flex, you're doing your mountain climbers, and you're just putting yourself back into that upper cross syndrome position.
Common training limitations include shoulder immobility, core instability, and difficulty maintaining proper form during vertical pulls, overhead presses, clean receipts, and even bilateral rows.
Okay, so what's going to happen is you're going to stop, using these muscles, and you're going to start using like your spine and other muscles because they become just so distorted that you have to start using other means to move and press.
Corrective exercises can include a variety of posterior chain pulls to help draw the shoulder complex back into a neutral position and improve activation of the mid-back and lower trapezius.
So basically just trying to get ourselves back to neutral.
Let's continue by taking a closer look at lumbopelvic hip distortions. First off, lower cross syndrome is another common postural issue.
Okay, that's this one.
Those who weightlift
See people that try to
as well as sedentary
stick their
individuals.
glutes out maybe naturally or unnaturally.
Somewhat similar to the upper cross syndrome, but impacts a different region of the body.
So anterior pelvic tilt.
Weakness and tightness of core and pelvic musculature causes excessive lumbar lordosis, trunk instability, the risk for hamstring and or groin strains, and lower back pain.
Okay, because if your pelvis is an anterior pelvic tilt, it pulls on the hamstrings, shortens your hip flexors, okay, and your trunk is not stable in an anterior pelvic tilt when it's more stable in a neutral tilt, and that's why we try to train in neutral, okay. Lower back pain, compressing the spine. If you're always compressed here, then yeah, you're not gonna have as much room for that spine to move freely, which is gonna keep that contraction.
The hip flexors, erector spinae, hamstrings, hip adductors, and calves become tight, strong, and overactive, while the gluteals, abdominals, and spinal stabilizers become lax, weak, and underactive.
Okay, lax, weak, and underactive. Okay, so if we're stuck short, we're kind of just staying in this weakened position where everything else here is turned on. Glute max is turned off when we're here as well. Iliopsoas, that's right in your psoas or your psoas major, it's right next to it.
This causes the individual to overuse their hip flexors and lower back for stability. Lower cross syndrome is often caused by sedentary behaviors, such as the desk job, poor daily posture, or imbalanced bilateral lower body training. Common training limitations include core instability, difficulty maintaining proper form during most bilateral hip and knee flexion exercises, such as squats, and knee positioning with heavy loading.
Okay, mainly caused by bilateral lifting. If you're always doing things on 2 feet, or if you're always deadlifting and you're always back squatting, and you're always on those 2 feet, and you're not taking, you're not doing one leg deadlifts or one leg squats, you're going to have more likelihood of getting that anterior pelvic tilt or lower cross. Because think, every time you squat, you're trying to not break your spine when you squat. So you're constantly doing that, unless you're doing it with good form, right? With a neutral a pelvis, you have the shoulder mobility to get your hands back. Because if you don't, you're going to cheat with your low back, and that's going to get worse, right? Belt. Well, we can create our own belt with intra-abdominal pressure. The belt isn't going to save us. And it's not something that I typically use or recommend, because then it's more of unless you're a pro power lifter, I would say yes, you're going to have to probably use belt at heavy lifts. But if you're not pro, or if you're not going to, try out to be in the Olympics, or if you're not an Olympic lifter, I probably wouldn't recommend a belt. You're probably going to be more at risk of injury than anything.
Exercises usually focus on using split stances and single leg actions during lower body training to reduce lower back strain and enhance gluteal activity. Now, in the frontal plane, fixed lateral pelvic tilting is another common distortion of the region. Reciprocal hip elevation and depression results in locomotion problems, leg length disparities, strains, and hip or lower back pain. Lateral pelvic tilts are caused by single-sided postures, such as always leaning to one side.
Okay, like sinking in this right leg. Okay, they're not talking about PRI or Postural Restorative Institute, but Postural Restorative Institute would tell you that the reasons why a lot of these problems are also occurring is because of the shape of our diaphragm and our internal structure, that we are biased to the right. Most of us are right-handed, right? Raise your hand if you right-handed. Okay, most of us. Okay, so we obviously, as a human species, are dominated by this right side. And so we tend to just be more relaxed, look, in this right side. So when I do that, I shift my hips down to the right. Okay, my left hip moves forward. When I do that, and when I breathe on this right side, I bring my right shoulder down. Okay, I turn on this right oblique system. I turn this off. Okay, and that sets up major postural deformation. So if you want more information on PRI, that's something separate, but they all kind of talk about the same thing, about these imbalances, about these asymmetries, about how to fix these asymmetries, how to fix these imbalances. And NCSF, PRI, and other certifications all have maybe similar views and maybe some different exercises.
Injuries or repetitive movements. The quadratus lumborum, iliopsoas, and adductors are tight and overactive on the elevated side, while the hip abductors, including the gluteus medius and TFL.
Because think about that. If I'm sinking in this right side, my QL here is doing a lateral flexion. So lateral flexion of the spine is QL, right?
Are tight and overactive on the depressed side. Common training limitations can include poor spinal and core stability, reduced balance during single leg activities, and difficulty maintaining proper form during most bilateral lower body exercises.
So that means that you're sinking into one hip when you bilaterally deadlift or squat. They did a study on bilateral lifting, squatting, and deadlifting, and they noticed that most people put most pressure on the right side. So you'll see most people will lean or sink into that right side and use their right side more than their left side. So some people might be opposite. They might have had injury on that right side and they use their left side. So you can't say that's going to be the case for everybody.
Corrective exercises usually focus on appropriate stretching and strengthening of the frontal plane musculature at the hip and thigh. To finalize this lesson, we will review lower extremity distortions at the bottom of the kinetic chain that commonly impact the knees, ankles, and feet. Most of these issues are caused by distortions starting at the hips and pelvis that cause a negative domino effect to the bottom of the chain. Common distortions in this area include ankle oversupination or overpronation, varus knees or a bow-legged stance due to external hip rotation, valgus knees or a V-knock stance due to internal hip rotation, or a combination of ankle and knee issues.
Okay, knee valgus. That's a position we don't want to be in when we squat, because that shows that we're underactive in the VMOs here, and we're underactive in the glute medius. So we want to make sure if we see our clients doing that, a corrective exercise, just put a band around their knees so that they have to push out, and then as they squat, they're focusing on keeping this out. Also, one leg step-ups would also attack that VMO or vastus medius oblique.
And your knees with flat feet. The muscles causing the distortions in this area depend on the combination of presenting issues. Most commonly, there is overactivity and tightness in the hamstrings, calves, and adductors, and underactivity, laxity, or weakness in the gluteals, vastus medialis, and abductors. This is not true in every case, and again depends on the causative factor, which can be far throughout the kinetic chain. Common issues with lower extremity distortions can include plantar fasciitis, shin splints, IT band syndrome, and jumper's knee. It is often difficult for someone suffering from these distortions to perform squats, compound pulls, or single leg balance exercises correctly. Corrective exercise commonly focuses on single leg reaching motions, as well as split stance work, to improve mobility and strengthen balances. This concludes the lesson on the inner and outer units, as well as postural distortions.
Nice. Okay, so let's just go ahead and take a little bit deeper dive into those sling systems. And this guy does a really good job. I think a little bit better job than NCS.
So our anterior oblique link, if we have a look here, links quite a few muscles of the abdominal area. I'm linking my external oblique on one side with the internal oblique on the other side. And these two muscles link via this central tissue here, known as the linea alba. So the linea alba is thick fascial tissue, and it carries a line from here.
The linea alba can actually separate, and you can have some major issues where some of your clients, if you see them do a sit-up and you see a protrusion of tissue, that's what is your linea alba.
And crisscrosses fibers from right to left, from left to right. So my external oblique on one side, that's the direction of fiber of my finger.
And I love that. I love that view of the external and internal obliques because I've never seen anyone, use that type of description or just label themselves. It makes it a lot easier to understand where the external oblique is. Where do the fibers of the external oblique go? They go at an angle like that, whereas the internal obliques go at an angle. So they go at different angles, but you don't understand why until you understand that sling system.
The internal oblique on the other side via the linea alba. So you see that direction on my shirt there? That's the fiber direction of the anterior oblique sling. Now we actually continue across the fascia of my pelvis to continue anteriorly into the adductor muscle group. So the adductor muscle group is this region here, having through internal oblique on the same side and external oblique on the opposite side. You'll see it is carrying across from one side to the other. So we think of that slingshot action of these muscles now recruiting with these muscles, and these muscles, it gives me a long line from here to draw my body towards the supporting leg. My supporting leg on the left draws the right side of my body across. And you'll see evidence of that in throwing, striking, punching, where this side is driven by that side. And I get the sling action forward. It's an anterior oblique sling, and you see the anterior pushing, striking, and throwing patterns. The anterior oblique swing.
So I think he did it.
So if I was loading up my oblique posterior sling, how do I load up my latissimus dorsi on the right side?
He doesn't go over it. He goes over something a little bit different.
Let's look at another sling system. This sling system is oriented posteriorly. So I'm looking here at a sling system that works from the lower via the pelvis into the trunk. This is called the posterior longitudinal sling. Posterior longitudinal sling links the bicep femoris muscle of the hamstring group, crossing my pelvis via the sacrotuberous ligament into the thoracolumbar fascia and the erector spinae muscle. So the bicep femoris into the sacrotuberous ligament of the pelvis, big, strong, powerful ligament, then attaches into the erector spinae and thoracolumbar fascia. So we see on our diagram here,
the thoracolumbar fascia. Where on there do you think is the thoracolumbar fascia? You think it's here, above, or in the middle? It's in the middle. So if you've ever heard, the bodybuilders and they try to show off their Christmas tree on their back, that's the thoracolumbar fascia, is what they're really trying to show you a screenshot of.
The sling will be wound up whenever I'm in a position of flexion, particularly through my trunk. So if I trunk in this position, the sling is under stretch. As I come out of this position, the sling ends up engaging force into that upright trunk position. So my hamstrings pull at this end to extend my hip, transfer force via the thoracolumbar fascia and the sacrotuberous ligament into my rectus spinae, which brings my trunk back to neutral. Activities such as jumping the ground, where I come from the part of the flex spine all the way up into my neutral spine, is a good example of using the force from this sling system. Exercise such as deadlift, particularly in the top portion of the deadlift, where my hamstrings are more fully recruited, and they link with a very secure erector spinae to assist me to extend my hip. These are exercises that very, very heavily use the posterior oblique sling system.
Okay. We have the
Let's look at a particularly important sling system that helps me gain lateral control of my body. So that I can control sideways movement, I actually have muscles and long sheets of fascia on the side that can assist in storing energy, releasing energy, and transferring energy. So this area here on the side, incorporating my glute medius and minimus, my tensor fascia lata, and the iliotibial band, gives me a broad coverage across the hip joint and the knee joint. And that allows me, in this diagram here, to have fascia coming into tension if ever I'm losing control to the side. It assists me to bring my hip back towards neutral. So these muscles take me from being off centre back into neutral. So as I land in the ground and change direction, as I strike in running, as I hit the ground in walking, the essential skill for me to do is to keep my pelvis neutral. I'm trying to keep this bit neutral because that will allow my head to line up with my toe and my hip to line up with my knee on a neutral pelvis in a way where the joints have their best functional positioning. And this allows the quadricep muscle group to work effectively. It allows the gluteal group to work effectively to help propel me forward in motion. So exercises that challenge single leg balance in particular work heavily on the lateral sling system.
okay. And then just push through.
As mentioned, the posterior oblique sling is the myofascial relationship between the fascia, the thoracolumbar fascia, and the sulci. It is important to note that it runs quickly, therefore the left version has a relationship to the right side. A great example of this sling in action is the debated lunge single arm row exercise. As the left foot is loaded, short of providing the energy required helps move the weight and thus to help the leg to that coordinate. Due to the attachment point of the lateral humerus, it can also be said to also influence the movement of the shoulder and the
Okay, so that kind of re-emphasizes those sling systems I think those videos do a little better job of kind of explaining the types of exercises you can perform, and hope you got a little bit of information out of that. All right. So, all right, I got some things we're going to go over on the whiteboard, and then we're going to perform a little bit of foam rolling today. We got foam rollers ordered. They're in that room there. They're not out. But the first thing I wanted to go over was just the light off over there. I guess I'm not sure why they're not going all the way on. See if this does anything. Oh yeah, there we go. All right. All right. So we're just gonna. Okay. Yeah, I wrote this on the board because if you answered yes on any of the Part Q questions, just stay after class. Just make sure I have your paperwork and we have that complete because I need to make sure I have all those Part Q forms in by the end of this week. If you haven't filled it out, you can stay after class and fill it out. Okay. All right. So without looking at any notes, go ahead and put your computers and stuff away. See if I can turn this all the way around. You think I'll be able to do it? What do you think? There we go. All right. So my first question is, what are normal blood glucose numbers? What do you think a good number for blood glucose would be? 90? Okay, good guess. Any other guesses? Where's my blue marker? 90? Anyone? Any other guesses? 100? Okay. 110? 85? 85? 85? Okay. So let me get my marker out here. Maybe it's in my pocket. Nope. Oh, is it? All right. I'll use red, I guess. All right. So levels that are under 100. Okay. So levels that are under 100. Okay. What do you think pre-diabetes fasting blood sugar levels are? If we're at 100 to be normal, what do you think pre-diabetes? What do you think the range would be between? 120 and 140? 120, 140? Okay. Well, it's going to be 100 because we would start above, right? Normal, which would be 100 and below. So if it was pre-diabetes, be 100 to 100 what? 20? Hendrik? Just guesses are good. 120, that's close. 130, we're right there. So 125. Okay. So pre-diabetes, if you're at a fasted blood glucose level of 100 or 100 to 125, then you're at pre-diabetes. Now, after who's ever had a glucose plasma drink and then tested blood glucose a couple hours later? So that's another way to find out how your body metabolizes sugar. You give someone a lot of sugar, you check their blood sugar levels 2 hours later, what do you get? What do you think after 2 hours of giving them straight sugar, what do you think it should be at for pre-diabetes? Okay, what do you think the range would be? To what? Wow, pretty good. No, you got it. 140 to 199. So so if they were to test your blood, they can do it either way, right? Fasting or after that 2-hour blood plasma. Now, what do you think diabetes would be your fasting levels? What do you think? It'd be equal to or over what? And this has a hint. 126. So they're going to put 126 for this one. Okay. And what do you think the 2-hour blood glucose would be? 200. Nice. Okay. So that's how someone might assess that. Now, are we going to be able to assess this? I don't know. Some of our clients might have devices that show us what their blood glucose levels are, but this is something that doctors would probably be more responsible for. Okay, diabetes is when your body is no longer insulin sensitive. Okay, so when you eat sugar, your body releases insulin by way of the pancreas, and what happens is we try to burn that sugar, and if we can't burn that sugar, we store it as fat. So people that have diabetes have eaten sugar and have not burned it off and have overstimulated your insulin response. And so over time, your insulin is like, I can't work anymore for you, so I'm just going to take this sugar and store it as fat. Okay, so that's what happens when you have diabetes. Okay, there's different diseases that can occur. Retinopathy. What do you think that affects? It's in the word. Retina. Okay, so that would be for eyes. Okay. What about nephropathy? What do you think? Kidney. Good. Okay, ED, erectile dysfunction can occur because limited blood flow. Cerebrovascular, where do you think that affects? Your brain, yep. And neuropathy, what do you think that is? Nerves, good. Okay, so diabetes can affect your eyes, kidneys, brain, and nerves. Okay, so if you're constantly storing fat, you're going to have more fat deposits, right? Because you're not able to get rid of the fat because we're not either working out or we're eating too much sugar. And our body is no longer metabolizing that sugar for us, so it's storing as fat. And the fat gets circulated, and it builds up deposits in plaque, okay? And that gets all the way to our blood vessels, to our tiny blood vessels that affect our eyes, kidneys, brain, and nerves. Okay, so if you have a client who has retinopathy due to diabetes, what might be an exercise you might want to stay away from with someone that has retinopathy or heightened retina disease? So like a leg press where you're getting really compressed and you're kind of building up that pressure is actually not good for someone with retinopathy. Okay, and these are the main causes of death of diabetes as well. Okay, make sure I have that on there. Okay, atherogenesis. What do you think that is? Atherogenesis. What do you think that is? That's the plaque formation that occurs in blood vessels. Okay, that's the plaque. That's what we don't want. That causes resistance, okay, in blood pressure, which increases blood pressure, okay? So cardiovascular disease is the leading blank of death. What do you think? Cause, yep. So cardiovascular disease is the leading cause of death, and having diabetes can increase your chances of having cardiovascular disease, okay? These are the main factors for having diabetes. You could have family history of diabetes, obesity, poor diet could lead to diabetes, gestational diabetes, you're born with it, and then physical inactivity. Okay, physical inactivity, you're not metabolizing sugar anymore, so you're storing it as fat. Your insulin levels, they're not resistant. They're becoming resistant to your demands. They're not, complying with what you need them to do. Okay, osteoporosis. What do you think that affects? Bones. Okay, what do you think it mainly impacts your bones or your joints? Bones. Okay, so osteoporosis is degenerative in the bones. Okay, What about rheumatoid arthritis? What do you think that is? Joints. Okay, this is the most severe out of all of them that you need to know. So this is the most severe. Okay, it mainly affects, where do you think it affects? Your wrists, fingers, hands, feet, ankles. Okay, osteoarthritis, what do you think that means? So it's mainly, yeah, it can be multiple joints, but it's not as bad as rheumatoid arthritis. That would be kind of the most severe stage. So osteoarthritis is failure of one or more joints, joint cartilage degeneration. And where bone remodels, it forms osteophytes, which are those bone spurs. So bone spurs can result in your osteoarthritis. There's degeneration. Okay. All right, high blood pressure, systolic and diastolic. What do you think would be normal blood pressure? What do you remember from blood pressure? What would be normal systolic? Yep, under 120. And dystolic? 80. Yep, under 80. Okay, what about elevated? What do you think elevated would be? 85. So this systolic actually doesn't change. Okay, it actually stays the same. But systolic does rise. What do you think systolic rises to? 120 to 129. Okay, what do you think stage 1 is? Yep. Let's see here, let me double check. And then what do you think dystolic would go to? So, yep, 80 to 89. Okay, next, what do you think the third or the second stage would be? 140 or higher. And what about your dystolic? Okay, 90 or higher, great. And what do you think would lead to crisis? Okay, what would be crisis mode? 180, okay, good. Where did I put that? And what do you think would the diastolic be? 100, okay, 120 or higher. Okay, so that would be kind of crisis mode. Okay, so has anyone had their blood pressure checked? I think I asked this last time. Anyone in the last year? Okay. It's good to get checked like once a year. It can fluctuate. Obviously, you go to the doctor's appointment, it can give you false results. If you do, maybe sometimes ask them to do it over. Sometimes you get nervous and it goes up. What about stage 1 obesity? What do you think stage 1 obesity? What body fat percentage for men does it have to be over? 20, good. What about for women? 26, good. Close. What about stage 1? Greater or equal to what for men? 25, good. What about for women? Stage 1 or stage 2? 32, close. Okay. What about stage 3 for men? 30, it's close. 35, good. Okay. What about for women? What do you think? It's going to be more than men. 45 would be for stage 3. Okay. What about waist circumference? What would be men's at risk for obesity? 40, good. What about for women? Good. Nice. And what about BMI? Now this one we didn't go over, but what do you think BMI would be? Okay, so if it's greater than 23 or 24, that's close. 22, a little further away. A little closer. 28, getting warm. 30. Okay, so BMI 30 and over would count as obese. And then what about for women? Men is at 30. What do you think, women? Almost. It's in the direction. Yep, 35. Good. Okay. So those are some good stats I pulled from the chapters that I think are probably the most relevant from high blood pressure chapter, or diabetes, high blood pressure, and then also looking at obesity, because they want you to know these numbers probably are some of the most important numbers you can have when you're working with a client. I mean, BMI, you can do that on your phones right now in your calculator and just look at height, weight, and gender, right? Waist is easy to do as well, okay? Now, getting body fat percentages, you can use, we have the electric, like magnetic one, where it goes through your body, and then you can do the pinch, you can go to the rec center. They have the underwater. Has anyone been in there? The pod, okay, the body fat pod. So that's, if you wanted to know exactly what your body fat was, I think that's probably the closest we can get to. But yeah, I mean, as long as you fit into one of these categories for, if you're under 20 for men or under 26 for women. Now, what about what do you think the essential fat is for men and women? So how much fat do you think men should have? Do you think it's okay to have 1% body fat? Would that be good? What do you think we should be at least at? Okay, 15, yep, 12, let's say 12 to 20. You probably wouldn't want to go on the low end of 12. And then women's essential body fat is probably going to be a little, lower or higher? Higher, yep. And I don't have those numbers. Those numbers you can look up. You can just Google right now, like, what is essential body fat for men? What is essential body fat for women? So someone go ahead and look those up for me. And we'll see what those are. So are you looking up men or women? All right, someone else do men. You want to do men? Essential body fat for women. What percentage is it? 10 to 13. So you need at least 10 to 13%. Otherwise, you have organ failure for women, or you can lose your period. You can have other issues. What about for men?
It says 2 to 5.
2 to 5. Okay, it might be a bodybuilding site, but I would, yeah, I mean, maybe it is 2 to 5, but I mean, I'd have to re-examine that one. All right, so you can take a picture of that. That's probably the best way to write that down. You don't have to actually write down. We're going to go ahead and do a little bit of foam rolling before we head out today, and we'll talk about what it does and the muscles that we're actually using. It said 2 to 5. Okay, 2 to 5% for men. I've been to 6% at one time in my life, and it's probably the lowest I've ever been, and I probably won't go back there. All right. So we have the half rollers. So we'll do a little bit of a 10-minute foam roller. So go ahead and grab a foam roller. One at a time here. Oh. All right, let's head out here. Find some space. You don't have to be in a circle. I'd rather have you more in rows than in a circle. Probably you have a little bit more room. All right. So we got about 10 minutes, which is about how long I like the foam roll for, or how long I prescribe foam rolling. You can do it before or after a workout. NCSF, they have programs where they have it in before and after. So I've seen them program foam rolling before and after their workout. So either or is good. I recommend doing it first because, one, we're assessing tissue quality. Is it dense? Is it not dense? Is it tight? Is it not tight? Okay, that's number one. Two, it helps increase range of motion temporarily, which can be beneficial when you're working out. Three, it makes you feel a little bit better And that in itself is good for our clients if they feel better about their muscle tissue quality, right? So the first thing we'll do is just start from the ground or the posterior lower aspect of the gastroc and Achilles, and we'll go one leg at a time. I'll start on my outside so you can see. I'm going to push my hands into the ground as I lift my bottom off the ground, and I'm going to roll forward and back over the calf. Okay, that's one way I can do it. Another way is I can cross over. I can put a little bit more weight into it, try to straighten that leg, and try to roll from my ankle to my gastroc. Another way I can do it is just bring my bottom down and go up and down. And as I go up and down the leg, I'm going side to side as well. Okay, I can get the outside of the perennials. Perennial longus and brevis, I think, is in there on the outside. I can get into that 90-90 position to work that area, which for me works the best because that always gives me a little bit of issue. All right, and you don't want to go into any pain. Let's go ahead and switch side. Again, you're just assessing tissue quality. You're giving yourself a slight massage, and you're moving toward any areas that you think are a little bit tighter, or you're searching and scanning and trying to find an area of tension. Sometimes you have to really search. Okay, so I might go on the outside. I might feel more there. I might feel more in my calf. I might turn my toe in. I might feel it more when I do that, or maybe that doesn't feel right, so I go back. All right, let's move up the chain. Hamstrings. A ball is probably best for the hamstrings, but we'll go over them real quick. We'll do same thing, one at a time, from the knee to the hip. And then if, for me, I don't really feel this as much unless I kind of turn my toe in just slightly and I get more of the inside. But then again, I feel like I'm trying to bias my adductors when I do that. So let's go ahead and switch. A tennis ball while you're sitting on a box might be better for your hamstrings, or a softball while you're sitting on a box if you don't feel anything here. If you do feel it in your hamstrings, like, ooh, those are tender, then this is probably just right for you. Okay? But if you don't feel anything as much, then again, like I said, something like a lacrosse ball, softball, or tennis ball could work while you're sitting on a bench. Glutes or glute max and hip rotators. I'm going to sit on the roller. I'm going to lean on my left side here. I'm on my left glute. I'm going to cross my left over right. My right knee is bent about 100 degrees and 90 degrees. And then from here, I'm going to lean into that left piriformis, glute max, and glute med muscles here. And I'm going to just try to focus on small rolls up and down that hip rotator. So hip rotators, glute med, you're getting glute max, you're getting your piriformis. Anytime you cross your leg and stretch, that's what they would call a piriformis stretch. Go ahead and switch side. All right, leaning into that side, crossing over, trying to get that foot really under the knee if possible, leaning into that side and then moving on the outside of that pelvic girdle there. Again, 5 to 10 rolls per side. If something's very, very tight, or if you feel like you need to pay more of attention to some place on your body, then you can also do that. You can also do this with your legs straight, like this. Okay, just so you know, you don't have to cross it over. For your low back, we're not going to do this. Woo! Show you what not to do first. Okay, don't go like that. We're just going to lean on one side, just like this. If you feel like you're sensitive with ribs, you don't have to do this one. Okay, we're just going to lean on that left QL, on the left low lumbic, thoracolumbar fascia on that left side. Let's go to that right side. Again, we're kind of cruising through this. I don't want to spend too much time on that low spine unless one side's a little bit tighter. And did y'all notice if your right side or if your left side is tighter? What'd you feel? Notice anything different? Right side's tighter, right? What about right, left, left, right, left, right, left, left, right, left. Okay, so I would say a little bit of both there. All right, now for upper back, this one, don't do it yet. I'm gonna go on my butt here, bend my knees, arms are teed out to start. I'm gonna line up in between my shoulder blades, and then from here, I'm gonna roll by holding onto my elbows from my mid back to my upper back. Okay, I can also bring my elbows together to get my scapula out of the way. This one's a lot harder to do, so don't feel bad if you slip off at first, but this is from the upper traps to the lower traps, and also your rhomboids and in through your scapula. All right, so let's go to our lats, pecs, posterior deltoids, and ribs. So we're going to drape our arm across and over the roller. From here, we're going to roll into our armpit and behind into our post deltoids, kind of into our pits, and then right into our latissimus dorsi here. So you're kind of getting all these different areas and kind of focusing on what area you kind of feel the most tense in. Okay. You don't have to do this one, but you can also get the pecs. Okay, just like this. You can focus more time on the post delts, or you can focus time on those lats. Let's go ahead and switch side. This would be a good one to do, obviously, before overhead or any pressing motion to loosen up those shoulders. Again, you can also, to make it a little bit more advanced, is bring your hands over your head. And then what I'm doing here is you have to kind of use this foot here to kind of move your body here. So it does take a little bit of practice to learn. And then I can also maneuver like this and try to find an area of tension. I can move my arm around, I can go forward and back like this. Okay. Now for the adductors, we're going to go into a plank position or a prone position. Abduct the thigh and bend the knee 90 degrees, dorsiflex the ankle, and put right on our VMO or vastus medius, and then go from vastus medius and really just small rolls on that vastus medius with our foot slightly off the ground. And you're going to feel that in that teardrop muscle, which is your vastus medius. So about 5 rolls there. And then we're going to go in the middle of the tissue. Okay, this is going to get the adductors, magnus, longus, gracilis, sartorius. And now we're going in toward the adductor brevis, gracilis, all the way inside. And there's 3 different areas there that you can pay attention to. All right, let's go ahead and switch. Again, going next to the knee. What muscle is that? Just yell it out. VMO, okay, vastus medius. Just 3 to 5 rolls there. I can go like this. I can put my foot on the ground, and then I can go internal rotation, and then back down. So I can actually make it a closed chain movement as opposed to an open chain movement, okay? Let's go to the middle adductor. And then let's go more inside. All right, now just yell it out. What side do you think was tighter, your left adductors or your right? What do you think? Right? Right? Left? Left? Right? Okay. So again, mainly rights there. All right, let's go ahead and put those back. We didn't do the quads, we didn't do the TFL or glute meads, but those are other things we can try next time. All right, we'll see you all